Very good. It's my pleasure to introduce our next speaker, our honored speaker, Dr. Stephen Lewis, who will be presenting on innovations in surgical management of congenital pediatric spine deformities.
Thanks a lot. It's a hard act to follow, but I'm going to try to bring it down we'll go down the spine a little bit and see how it looks. See if everything shows up here. Do you mind, sir? Go direct. Check it out. Okay. Thanks a lot, guys. So we're going to bring it down to the thoracolumbar region, and I'll go over some of the basic congenital deformities that we know of, some of the operative options that we have, timing of surgery, which I think is very important. I'll go over some of the osteotomy things that we do and some of the principles that we've kind of adapted to our adult or more severe deformities. So these are complicated cases, and you really have to get everybody on side. And let me see. Sorry.
What are you thinking about?
So you have to make sure everybody's on the same page and really understanding what's going on. And sometimes there are some communication problems between anesthesia, neuromonitoring, and things like that, that it's very important that we all are on the same page. I'm sorry about the sound on that one, but so there's different congenital. The main defects that we see are really failure of segmentation and failure of formation. And there's been some very well described things. Some of the current, principles are whether it's segmented or non-segmented. Segmented means it has its own disc, its own vertebra, its own everything. Semi-segmented, so maybe partially fused. And then if it's incarcerated, it gets incorporated into the adjacent levels, so it may not be as deformed, for example, and then it can be non-segmented that way as well. So there are all these things, and how it is and how it looks will definitely influence some of the techniques that you use. Obviously, cutting through a disc and cutting through a bone are going to be very different, and the way you get the correction done is going to be different as well. And so there are all these things. We know that probably a unilateral hemivertebra with a contralateral bar is one of our worst kind of ones at high risk. But at the end of the day, there's these classifications. And then when you see some of these kids, anything goes. And you may see things that really don't classify at all. And so it just gives you an idea of what to do and then kind of see if they all balance off. This is a famous article by McMaster trying to do what is the natural history of progression of these deformities. And you can see they looked at it different, obviously there's smaller numbers for some of these cases, but really if you have an unsegmented bar, unilateral unsegmented bar with a congenital hemivertebra had the highest risks of yearly progression in these cases. So what I think in these deformities that is much more important really to recognize is whether you're dealing with a focal deformity or whether you have a global deformity. And it changes everything. And if you can get it at a focal level before it changes into a global level, then you can limit your surgery to just a small level. But once you have a global deformity, a focal correction is not going to be sufficient. And so whether that's at 4 years or 6 years or 8 years, it's just before it happens. And I would say that it's very important. I'm going to show you some cases where we caught early, where we fixed it, and you can see the natural history, and ones where we have to deal with it because we have to manage it late. And so I would say the most important is to treat the cause of the deformity. So if you have a hemivertebra or a bar or things like that, I would say that a focal correction is sufficient if you have just a focal deformity, and you may have to brace some of the other parts. So if you have a L4 hemivertebra, you may have to brace the lumbar spine during growth, but that's something you have to watch for. And then I would say that if you're going to correct it fully so that the degrees is as close to 0 as possible, so that if you're going to have a focal deformity, that it'll be able to progress and do well. If you have a global deformity, you got to treat the whole curve. So you have to treat your cause and the same effect, because just treating the hemivertebra is not going to do anything for you, and you're still going to have progression. You're going to still have a pretty big deformity. And so treat as you would any case, depending on so if you're doing a 4-year-old, you may want a growing system. If you're doing a 12-year-old, you may just do an automatic fusion right off the bat. So you have to kind of decide where you're at in the stage of the kid. So here's one, a 13-year-old, very severe T11 hemivertebra with a very big deformity, kyphotic and scoliotic. We took out actually 11 and 12. And did I usually take the body out and put it back in the front. I can't afford a cage in Canada. And so this is what we end up with a pretty nice correction. And you can see here another global deformity with a hemivertebra. So do the hemivertebra resection and combine it with correction of the curve. So it's just part of the extra release that you need to do. We add some Smith-Petersons, we add whatever other osteotomies we do to get the spine flexible. But you're kind of forced at this stage to treat the whole curve. Another one, it looked like a bad scoli, but then we got a CAT scan. You see this hemivertebra embedded inside, and obviously that has to be addressed at the same time as doing the correction. So those are all different cases. And if you have a global deformity in a growing child, though, you may treat it a little bit differently. So here's a 6-year-old with severe VACTERAL syndrome, already a huge leg length discrepancy, already had multiple surgeries on their legs in terms of femoral lengthenings, pelvic osteotomies. And then you can see the severe complex deformity, both of the spine and the chest wall. So at 6 years old, you prefer not to fuse someone like this and give them a very short chest. And so we treat them, I usually do a 2-stage. So I do my anchor surgery first. So we do that, let it sit for 4-6 months, let it fuse, and then go back. And then in this case, I do a reverse Schilla where we don't fuse the apex. We kind of osteotomize the apex, and then I use a growing rod system, and then we added on, in this case, a rib to pelvis distraction to correct her deformity. Now, she still needs a lot of work on her legs, and I think she's been treated in Tampa, and she's going back and forth from Toronto to Tampa to get her back and her legs fixed. So, and then when you see something like this, this isn't really a spine problem. This is a respiratory insufficiency problem, and probably fixing the chest is really what you need to address and make sure their lungs grow as long as possible. There's just no osteotomy you're going to be able to do through that spine to make any significant improvement. So when should we operate on these hemivertebras? Well, here's a case of a congenital. You can see really no global deformity, but really interesting global decompensation. You can see that there's thoracic lordosis, lumbar hyperlordosis to compensate for a focal problem. And then you can see we just correct the deformity, and you can see the correction of the deformity, and the kyphosis comes back, the lordosis comes back, and basically a global alignment. But here's a very similar case, a 4-year-old with a L4 hemivertebra and a 28-year-old with an L4 hemivertebra. Very similar CTs, if you look at them. And I have, you can see the progression for the hemivertebra, but she's a perfectly healthy girl. This is the only thing, there's a little abnormality in her sacrum as well. And you can see this fully segmented hemivertebra on L4. And the good thing about it, I did it very early in my career. I've seen her at age 21 in follow-up. We have kind of yearly x-rays. You can see it's fully segmented. We did just a focal correction at age 4. You can see 3 months, 2 years, 5 years, 7 years, 9 years, 15-year follow-up, age 19 right now on this x-ray. And you can see never progressed. So pretty incredible. You have someone who has a focal deformity, treat it fully at a young age, and I never had to do anything for her. And we even have an MRI. And you can see the laterals were really interesting. And you can see that because of her posterior fusion, she ends up hyperlordosing a little bit because there's nothing to stop the anterior growth. So just a little bit of extra lumbar lordosis in the bottom. But I thought this was really a nice case to show that if you can treat your focal deformity early, get it before a global deformity, you're going to have a much more limited and probably a much better outcome for these patients. And you can see even we got an MRI for fun, and you can see even the L5S1 disc survived us at this stage. So overall doing very well, and I think it's really important that if you have a focal deformity, get it before it's global. And I have a nice case, and this is kind of the opposite of a 28-year-old that came to me untreated with a very, very similar L4 hemivertebra. And you can see the deformity, the MRI had degeneration all the way through the bottom. And we did a hemivert resection and some osteotomies. And you can see he needed a T10 to pelvis to address his deformity as opposed to a single level fusion that could have been done perhaps if we got it before the secondary global deformity got much. And here's one that I have to take credit for watching this girl. They really didn't want surgery. And you can see a hemivertebra, and I watched her 4, 5, 6, 7, up to 11. We finally did her surgery, but you can see there's already a global deformity already developed. And then here's her sagittals. And so we did a short fusion, but it didn't work. And so we ended up, I did a hemivert resection with a 1-level fusion and got it too late in this one. And she progressed and ended up needing a longer fusion down the road. So I would say that how long is too long is you just have to get it before the global deformity starts. And whether that starts at 8 or at 6 or at 4, I don't know. But I would say that once their bones are big enough to put screws and there's no global deformity, I would say take the opportunity and you'll have a good on an isolated hemivertebra, for example. So maybe some of these more complex other deformities and other congenitals may have a different. And so you can see here's a 19-year-old with an T11 hemivert, very aggressive deformity already. And this is not someone that's going to do well with a hemivertebral resection. It needs obviously a lot more to get this corrected. We did actually took out 11 and 12. For some reason, I have a lot of 11s and L4s. And so this is kind of some of the red pictures that we have. We took out 11, then we took out 12, saved the nerve roots, temporary rod, closure on the convex side, compression, distraction, finish, and you can see we had a nice result for a very complicated deformity. Just because there was a deformity globally, but it wasn't as structural, so some Smith-Pete's through taking care of the apex and loosening up the rest, we got a really nice correction for this patient. When I started my practice, I inherited a lot of hemiepiphysedesis surgeries, and I would highly recommend, I think it may work for knees. A spine and a knee are not the same. And I would say that this is the big difference between a spine and a knee is crankshafting. Okay. And the knees may not crankshaft. The spines don't do very well on these. And I took some pictures from Dr. Azizi, which I got he shared with me. But I would say, because of the crankshaft phenomena, I would highly recommend. I don't think it's a useful operation, these hemiepiphysedesis. They probably do it, a lot of them in global deformities already, and then I think it's out. You missed the boat once you get to that stage. And I can show you some of the ones that I've had to do, and these are much more complex cases. You can see the hemiepiphysedesis anterior and posterior to prevent crankshaft, quote unquote, and you can see the terrible deformity that you get. With the girl, we ended up doing apical resection with some other osteotomies to get what we could from a very difficult, and the chest wall deformity still kind of stays because the chest wall becomes quite structural deformed. So you have to be quite careful on how to manage that. Here's another one. These failed hemiepiphysedesis surgeries ending up needing a more complicated procedure. And here's one, quite a bad deformity. You can see just lying down, he has a red mark on his back. He had a front back hemiepiphysedesis. And you get in there, it's a mess, big fusion masses, a very complex deformity. You're only going to get the correction through the area where you do your osteotomies. This after the implants, this is kind of what he looks like. This is our resection that we did. A big decompression around the osteotomy, temporary rod we put in after, and then do closure of the osteotomy. This is what we can get for him. And a big improvement. But he actually came back 7 years later because he wanted me to do some more for him. So we got a good correction for him. And then 7 years, we actually did another osteotomy to get a little bit better correction for him because he still wanted a little bit more. And this is, even with this, there was a big chest wall deformity that would not fully reverse, but obviously a much better correction for him, but needed 2 shots for some of these more aggressive procedures. So this was actually another good case that I learned from, many congenital anomalies. Looks like a very complex, but at the end of the day, it's mainly just a sagittal deformity. And you look at the patient and everything's fused. He's kind of a late teenager when we did his surgery, and you can see he's got this kind of thoracolumbar kyphosis, which is his main thing. And you can see his sacral slope is 0, so very high pelvic tilt. You can tell that by his underwear slope. And this is someone that, you look at it, and my colleague said if you do his surgery, he's going to suntan for the rest of his life. And you have to be really careful. But the truth of the matter is he has 30 degrees of compensation through his pelvis. And so any osteotomy is going to give that back. And so we ended up doing resection from him. We did a kind of a PSO type maneuver, and you can see this is called a furcal nerve root, which you see in congenital anomalies quite often. And so instead of the nerve root coming on, it comes off the level higher and meets laterally. So it's not uncommon. It's about 5% in the lumbar spine. So it's a common cause of a double root syndrome that we see. And so it was just interesting when we dissected him out when you have a congenital deformity, that you have no idea where the nerves are going to be, and just dissect slowly and try to find them all, because it's very important. Just because the bones are abnormal, I can imagine the nerves and the vessels are going to be abnormal too. So make sure you just take a little extra time, because you may not have the nerves coming off where you think they are. We use a central rod technique to close the osteotomy, and this is we published this many years ago, and you can see we put a hook above, hook below, spares the screws completely and squeeze the crap out of it. And you can get a really nice correction, 1 click at a time. And I usually put the main rods in. The screws never had to work a day in their life. And then we take the central rod out, and you can see the correction for him. So nice, pretty much a very complicated congenital deformity, but at the end of the day, it was just a sagittal plane deformity that we had to address. So we've taken actually this hemi-VCR, or these hemivertebrectomies. I've actually been using it on my complex procedures in adults, and so very high-end deformities. We published this this case report about over 10 years ago, where we did it for this girl that we kind of misjudged her proximal thoracic curve on a Elenke 2. She ended up with a high shoulder. We ended up doing this hemivert resection at a T4 and correcting her, and came out very nice. And we've been doing this now for more of these very aggressive, sharp, angular curves that perhaps a Smith-Peterson's not going to be enough, and a VCR may be a bit too much. And so we do these kind of vertebrectomies. Even though they don't have a hemivertebra, we just cut our own hemivertebra out on our resection. And so you don't have to worry about anterior column support. You have much more control of the anatomy, and then close it down. You can see really we've been getting some really nice corrections with very focal deformities, combining them with multiple Smith-Petes as well. This was a 14-year-old I did with a very high proximal thoracic curve. You can see a very aggressive curve, nothing congenital about it. We ended up doing a hemivert resection combined with multiple Smith-Petes, and got a very nice correction for her. And so just even for my adults, I'll just go briefly. Here's a patient that was treated with a L2 to S1, had some SI joint pains. We added some screws. But you can see he's got an auto fusion through his upper lumbar, and had a suit at 5'1". So we addressed that with a hemi resection through his, did an osteotomy through the, I think L3 we did, kind of a hemi PSO kind of type of surgery. So that's kind of what it looked like through there. And you can see the CT after. You can see the alignment, the osteotomy, hemi PSO, and we did it front to back. So we got a little bit of more sagittal plane correction. You can see a nice correction through his deformity. So doing a similar technique, using it for non-congenital deformities. Similar one for a very aggressive curve. Again, nothing congenital about it, but you can see the post-resection where we got a very nice correction on something that would probably need a lot more otherwise, and giving very strong focal apical correction. So congenital deformities are very homogeneous disease. You have to differentiate your focal from your global deformities. I would recommend early surgery for focal deformities. Get them before they get watch them closely. I would say after age 4, I'd really watch them closely so that they don't get their global deformities. Global deformities you have to treat according to their regular principles of their age groups and things like that, whether you're going to do growing rods or fusions. And the concepts of hemivertebrectomies are translatable to larger non-congenital deformities as well, which we've been using in some of these bigger deformities. So thank you very much. Okay.
Thanks very much, Dr. Lewis. I have a question about the sort of hemi-VCR for the non-congenital deformities. It's, I think, a great technique for addressing and shortening the spinal column for these more severe idiopathic type curves. What is your, what levels of decompression do you achieve before you start the resection? And then do you have any worry about cord stretch on the concavity, or because you're shortening everything, is it something that's kind of mitigated?
I mean, I don't do it at more than one level, and so I usually combine it with a Smith-Peets, and I'm very careful on the neuromonitoring, obviously. But I find one level shortening I tolerate very well on a severely deformed patient. I would say more than one level shortening, I'd be a little more concerned. I've gotten away with it on my Eng-Spawn cases. I can do even 3 segmental osteotomies on those, but on these kind of coronal plane deformities, I would recommend doing more than one apical one. On the first stage, if you want, maybe a second stage would work, but on a single stage, I would only do one. But I combine it with if you get a mobile level, the Smith-Peets are a real workhorse, and I think you can really supplement a lot of the correction that way.
And one other question about, you mentioned the conjoined nerve root encountered in the lumbar spine congenital case. Do you have any tips or tricks for imaging that? I feel like we don't always get a coronal T1, but do you request that specially, or what's your
I find it, I can't find them on the MR very clearly.
Okay.
Even I look on the axials and I can't be sure. Sometimes you can see that, that Mickey Mouse is a little bit different on the T1. And I agree, the T1 axials is really helpful to see the nerve root. But if you don't see it normally, I would just expect something different. But I always expect something different.
Okay.
Anyways,
so you're looking for it.
So I'm just careful. I'm a lot more careful digging them out. Because even if the nerve root comes off high, it's still aggravating because it may block your access to the disc, which is a huge problem in some of these cases, because you may not be able to get to the disc on that side.
On the patient that you went back after 7 years to take a second shot at it, is that something you commonly do? Do you always leave the door open for a second procedure, or is that a special case?
I always if you look at it and you say, I need 80 or 90 degrees of correction, and I'm probably not going to get that on one shot. And so I always tell them that I'm going to do what I can on my first one. And if you don't like it, we can always do another one. And some we do a stage, and then 6 months or a year later, we do the second stage because, we have 3 goals of spinal deformity surgery. So 1 is the patient's alive, 2, they're moving, and 3, a nice x-ray. And so unfortunately, I have to do number 1 and 2 before I get to number 3. But those are the 3 goals. So, you look at that and you say, I can't do this with one osteotomy. There's no way I'm going to get that from an autofused spine through the apex. So I told him right away that I think he was a little too scared. It took him 7 years to come back for the second one. Some of them are a little more aggressive, and at 1 year they book their revision. So, but I would say take what you can get safely. That's the most important. You can always come back and do more, but make sure you never want an irreversible complication that you can't come back on.
So I have a question. A great talk. I mean, obviously, very challenging cases. Excellent result. I know, with the social economics of Canada, some of the technology or let's say BMP is limited. Do you use BMP for these?
No.
I've seen your other talks before. There, you have a lot of tips and tricks to maximize fusion without using that. Are there any tips you can give the audience to how do you achieve fusion through the lumbar sacral junction or PSO site? And
I can show you. We're like squirrels. We just keep any piece of bone I can get. So if I took a rib out, I keep that rib. We fashion it. We jam it underneath. If I have a posterior column deficit when I'm finished, I fill that rib underneath the rod. we've published our posterior column reconstructions. I can find some pictures. If you have 2 minutes, I can find some pictures for it but we're really aggressive on reconstructing the posterior column. And so I do not leave a gap in my posterior column. There is no gap. And we even published 81 3-column osteotomies. I had 3 broken rods at the osteotomy site. And they were all 3 interesting. 2 out of 3 were ink spawn cases who were smokers. So you would think that they would fuse. But I'd say being very aggressive on restoring the posterior column, because I think most people over resect the back and then they rely on multiple rods to get it. And I don't have that. Then they throw BMP and lots of other products, and I can't. They would take away 3 OR days a month if I did all that stuff, because I wouldn't have the budget. They'd close me down early. So you have to kind of budget on what you can do. So, but you can get a great result with good bone. It just takes a lot more time and a lot more really harvesting everything.
Thank you very much.
Okay, thanks, guys.